All right, so again, I'm Michael Awad. I'm a minimally invasive surgeon at Washington University in St. Louis, and I'm going to kick us off with a discussion on esophagus, stomach, and obesity related topics. So here's the first question, and again, if you missed the instructions, they're always up at the top here. We're going to have you respond at pollev.com/absite, and you can text. So here's the first question. In patients with gastroesophageal reflux disease, the severity of esophagitis is influenced by all of the following except presence and size of concomitant hiatal hernia, omeprazole, time of mucosal exposure to a pH less than 4, prolonged exposure to bilirubin, pH greater than 7, or decreased length and resting pressure of lower esophageal sphincter. And remember, this is an except question. We have a timer at the bottom left corner, which I'll use to just kind of help keep us on track. Okay, so the correct answer is indeed prolonged exposure to bilirubin at pH greater than 7 is not related to severity of esophagitis. The first letter A and the last letter E are related. That is, a hiatal hernia can certainly affect esophagitis. The bigger the hernia, the more it influences the patency of the lower esophageal sphincter and can lead to esophagitis. Obviously, omeprazole is used to treat esophagitis pretty effectively, and the time of mucosal exposure less than 4 is important, as that's really kind of the cutoff for the metric that we use for acid exposure. A pH greater than 7, while can be causing significant symptoms, is not typically associated with increased esophagitis. All right, our next question. Jejunal ileal bypass was formerly performed as a weight reduction procedure. The operation was abandoned because of the development of serious long-term complications associated with the procedure. Which of the following statements correctly characterizes results after a jejunal ileal bypass? Bacterial overgrowth in the bypass segment can be managed with oral vancomycin. Kidney stones occur with increased frequency because of absorption of pyruvate from the colon. The most serious complication of jejunal ileal bypass is the development of cirrhosis as a result of protein-calorie malnutrition. And rapid weight loss after jejunal ileal bypass is associated with development of endometrial cancer. Okay, so the correct answer is indeed C. The jejunal ileal bypass has largely been abandoned probably because of this complication as a significant bypass where the jejunum is anastomosed basically to the distal ileum, resulting in severe malabsorption, resulting in protein malabsorption, development of cirrhosis, and in fact hepatic failure is an indication for reversal of the bypass. Typically, bacterial overgrowth is not managed with vancomycin, but metronidazole. The multiple kidney stones are caused by excessive absorption of oxalate from the colon, where it's normally bound with calcium. And endometrial cancer is not related to bypass. Okay. Next question. Regard to operative management of gastric carcinoma, which of the following statements is correct? Long-term survival is rare if adjacent organs must be resected to achieve local control. Extended lymphadenectomy includes nodes along the aorta and esophagus has been shown to improve survival in North American trials. Resection of margins of 2 centimeters are necessary to prevent recurrence. And prophylactic splenectomy has been shown to improve outcome among similarly staged patients. Okay. So the correct answer is A. And so let's talk about this one a little bit as there was some variety in responses. So in gastric cancer, microscopic involvement of the resection margin by tumor cells is associated with a poor prognosis. Unlike colon cancer, gastric cancer usually has extensive intramural spread. Several studies have shown that a line of resection 6 centimeters from the tumor mass is necessary for a low rate of recurrence. The role of extended lymphadenectomy in gastric cancer is controversial. The largest experience has been in Japan, where there's some studies retrospectively that have shown improvement of 10% stage for stage, but not confirmed really in Western countries. Histologically, positive lymph nodes are seen more often in the splenic hilum and along the splenic artery, but prophylactic splenectomy has not been found to improve outcome for similarly staged patients. Okay, next question. Which of the following statements is true concerning the pathophysiology of GERD? A Schatzki's ring is usually seen in the mid-esophagus and is usually associated with significant obstructive symptoms. Repeated exposure of the lower esophagus to gastric juice results in transformation of the squamous epithelium to columnar epithelium. The development of intestinal metaplasia and the cardiac type mucosa can set the stage for malignant degeneration of squamous cell carcinoma, and a patient may compensate for GERD by yawning. Oops, that's sorry. Okay, let's go over that one a little bit. So the correct answer as coming up is indeed B. So basically, the first one is not correct. Schatzki's ring is usually not associated with significant obstructive symptoms. It's usually pretty benign. Indeed, that's the mechanism of Barrett's, is exposure of the lower esophagus to gastric juice. And the development of intestinal metaplasia and cardiac mucosa is not developed into squamous cell, but is actually adenocarcinoma, otherwise known as Barrett's cancer. The last point is, yeah, it's kind of a funny answer. They don't really compensate by yawning, but they actually do compensate by increased swallowing of saliva, which can lead to excessive bloating and belching and aerophagia. That's why some patients complain about those symptoms. Okay, the next one, which of the following statements about esophageal reflux is true? Manometry alone can identify more than 90% of patients with severe reflux. 30% of patients with symptomatic GERD will have no endoscopic evidence of esophagitis. The severity of reflux esophagitis seen endoscopically correlates poorly with ascent of esophageal dysmotility. Careful screening of patients with reflux symptoms using a scoring system will increase the rate of positive pH studies to 80%. And the size of hiatal hernia bears no correlation to the degree of esophagitis. Okay, so the correct answer is indeed B. So the first one, though, manometry alone is not sufficient for identifying people with reflux, although it is an important part of the workup. It is not specific for reflux disease. The second answer is the correct one, and indeed 30% of patients with symptomatic GERD do not have evidence of esophagitis. That's why pH testing is so important to help confirm the diagnosis. The third one, it actually is not quite true, and that the higher degree of reflux is doesn't quite correlate with the the severity of the reflux does correlate actually with the extent of esophageal dysmotility, as people with long-standing reflux can have significant dysmotility. And the last one is not quite accurate, or sorry, little d. If scoring systems based on severity were used to screen candidates for pH, it would be the presence of reflux would be documented less than 60% of the time. So unfortunately, symptom scoring sheets like the GERD HRQL aren't terribly specific for picking up reflux. All right, number 6, the most common cause of gastric outlet obstruction in adults is hypertrophic pleural stenosis, adenocarcinoma of the stomach, duodenal stenosis secondary to peptic ulcer disease, gastric lymphoma, or BZOR. Okay, the correct answer is duodenal stenosis secondary to peptic, I'm sorry, excuse me, adenocarcinoma of the stomach. This is one we do need to talk about for a minute. Letter C used to be correct, and until about 20 years ago with the advent of H2 blockers and PPIs. However, we're seeing much less of that now, and so actually the predominant cause is adenocarcinoma of the stomach. Duodenal stenosis from peptic ulcer disease is down to about 20 to 30% of cases nationwide nowadays. Hypertrophic pyloric stenosis, remember, is a pediatric condition treated with a pyloromyotomy, and the other causes are much less frequent. All right, next number. Which of the following statements about H. pylori infection is true? Of all the tests for H. pylori, the 13C breath test is the most accurate and considered the gold standard. If a proton pump inhibitor like omeprazole is added to standard therapy, ulcer healing time will increase. Duodenal mucosal function such as bicarbonate secretion will return to normal after eradication of the organism and healing of the ulcer bed. And the CLO test appears to have the best sensitivity, specificity, and accuracy for patients younger than 40. Or a possible mechanism for mucosal ulceration is H. pylori's ability to block inhibitory reflex pathways between the antrum and the proximal stomach. Okay, so the correct answer here is the last one, E. So let's talk about this one a little bit, as there's some difference of opinion here. And so this question really deals with the interplay and mechanisms of H. pylori and its relationship to duodenal ulceration. One of the theories is that H. pylori infection of the antrum blocks the inhibitory reflex pathways from the antrum to the gastrin-producing cells and the parietal cells of the proximal stomach. This results in hypergastrinemia and increased prolonged acid secretion, leading to duodenal ulceration. The scarring of the infection of the H. pylori causes scarring of the duodenal bulb, which can replace the normal villus surface with functional metaplasia of the mucus that doesn't quite work as well, such as it doesn't secrete duodenal bicarb even after the H. pylori is eradicated. Addition of omeprazole actually doesn't reduce the healing time compared to the other agents, but it can provide symptomatic relief. And while all of these tests are described for treating or for diagnosis of H. pylori, like biopsies, CLO tests, and so forth, none is actually really considered a gold standard, especially in younger patients. Okay, next question. A 40-year-old man is admitted to the hospital after vomiting blood. Endoscopy shows a bulging mass on the posterior wall of the mid-stomach covered with normal mucosa with a small bleeding ulcer in the center. What is the most likely diagnosis? All right. Very good. Yep, the correct answer is a GIST, or a gastrointestinal stromal tumor. These typically appear as a submucosal bulge in the stomach, typically not friable or ulcerated as some of the other lesions are. So this is indeed a GIST. All right, the next one, number 9. The major risk factor for squamous cell carcinoma of the esophagus is GERD, cigarette smoking and alcohol consumption, prior caustic injury, or H. pylori infection. Okay. So, yep, very good. Cigarette smoking and alcohol consumption. Just as a quick review, this one is a frequent one on the ABSITE. Um, the other factors that are also thought to be in addition to alcohol and smoking are nitrosamines and other nitrosyl compounds, typically in smoked meats. Sometimes achalasia can be associated with it. Longstanding achalasia, the risk of squamous cell carcinoma is thought to approximate 7%, and as well as a few other rare conditions such as Plummer-Vinson syndrome and caustic strictures. Number 10. The endoscopic appearance of duodenal ulcers can be used to predict the likelihood of rebleeding. Which of the following is a sign of increased risk of recurrent hemorrhage? Ulcer located in the pyloric channel, clean ulcer base, ulcer located in the second portion of the duodenum, visible vessel within the ulcer base, or ulcer greater than 1 centimeter in diameter. All right. Well, pretty much got this one right. Don't need to spend a lot of time on this one, but obviously a visible vessel is associated with up to a 70% risk of rebleeding and significant increased mortality. So good job, everybody, on that one. We'll move on. All right, number 11. Which of the following statements is true concerning the surgical anatomy of the esophagus? Access to the entire thoracic esophagus can be obtained only through the left side of the chest. The lower esophageal sphincter can be recognized distinctly by means of inspection of the GE junction. Surgical exposure of the cervical esophagus is best gained through the right side of the neck. And spontaneous esophageal perforation tends to be associated with leakage into the left chest. All right. Very good. And so, yeah, this one, just a quick description of the anatomy here. So typically the distal third of the esophagus is more susceptible to leak. It's surrounded by very thin, membrane. It is typically where spontaneous perforations occur. And its proximity to the left chest is where typically these effusions are first detected. Hint, hint, this is going to come up in a later question. For those of you just joining us, welcome, and also wanted to just remind you all that you can respond to our polls through pollev.com/absite, or texting ABSITE to 22333. You also have a chat feature in your box if you want to send us any questions. We can try to answer them as we go along. All right, next question, number 12. A patient with gastric adenocarcinoma undergoes subtotal gastrectomy. Pathology shows the tumor penetrates to the serosa. Regional lymph nodes are not involved. Distant metastatic lesions are not detected. What is the correct tumor stage and the 5-year survival rate? And I'm not going to read them. You can see the answers on your screen there. All right, so this one is indeed a stage 2 based on its tumor penetrating to the serosa. That's N0 and M0 based on no nodes or metastatic lesions. And so this is a stage 2. Generally, this has a 45% 5-year survival rate. In general, a stage 1 lesion is a fairly favorable prognosis. Stage 4 involves distant metastatic disseminated disease, and the survival rate is pretty much negligible. But this one is important as this tends to come up on the ABSITE from time to time. All right, number 13. This is about a 50-year-old man who had a 2-year history of a duodenal ulcer and then has severe epigastric pain 4 hours ago. Temperature is 101, heart rate is 80, blood pressure 125/90, and he's got a rigid abdomen. You have pneumoperitoneum on an X-ray. Laparotomy, you find a perforation in the first portion of the duodenum anteriorly. What is the optimal treatment? Omental patch only, omental patch with truncovagotomy and pyloroplasty 8 weeks later, omental patch with administration of antibiotics against H. pylori, omental patch followed by cimetidine, and omental patch followed by a truncovagotomy and antrectomy after 8 weeks. Okay, good. Yes, the correct answer is indeed C. Just doing the omental patch by itself is not sufficient. As many as 80% of people will have recurrent ulcers, and so a definitive ulcer operation should generally be performed at the initial time of the surgery, as long as the patient's not in shock, the perforation has been less than 48 hours, and there's no other life-threatening medical comorbidities. Definitely a safe approach would be an omental patch, and then postoperative treatment with omeprazole and clarithromycin if H. pylori has been detected. Okay, this one is a 45-year-old man with a history of alcohol abuse in the emergency department with hematemesis, tachycardia but no hypotension, is given a liter of lactated Ringer's with normalization of the heart rate. An NG tube puts bloody drainage and rapidly clears with warm saline lavage. What is the appropriate management? Immediate EGD, immediate IV infusion of vasopressin followed by EGD, immediate upper GI contrast exam, or observation in the ICU followed by EGD in 24 hours. All right, very good. Yeah, immediate EGD is the correct answer here. I see a number of people chose letter D, and it's a good thought. The idea here was that the patient, although initially tachycardic, was not hypotensive. They responded well to just 1 liter of lactated Ringer's, and the lavage clears pretty quickly. So they actually are a candidate for immediate immediate EGD. But the broader point here is that early EGD is very important in identifying these lesions. Generally within 12 hours of admission increases the likelihood of finding the lesion. After about 24 hours, fewer than 20% of the lesions are found to have active or recent bleeding. So early endoscopy is the key part of this question. All right, we got one more question here, and then we're going to switch gears. Which of the following statements characterizing gastric lymphoma is correct? Peak incidence of gastric lymphoma is in the second and third decades of life. Gastric perforation occurs among 40% of patients treated with cytologic agents instead of gastrectomy. Endoscopic biopsy provides enough information for a diagnosis in the majority of cases, and 10% of gastrointestinal lymphomas occur in the stomach. Okay, yep, the correct answer is indeed C. Just a couple of notes here. So indeed, endoscopic biopsy, sometimes with brush cytology, usually gives a diagnosis in the vast majority of cases. The stomach is the site of, more than 50% of gastrointestinal lymphomas, and is the most common organ with extranodal lymphomas, so that makes the last answer incorrect. And the gastric perforation rate is actually not very high. It's approximately 5%. It makes B incorrect. All right. So now that concludes the foregut section. We're going to go ahead and switch gears here, and I'm going to introduce our next presenter, who is Dr. Jeffrey Blatnik. Dr. Blatnik is also minimally invasive surgeon and hernia specialist, also here at Washington University in St. Louis. Welcome, Dr. Blatnik. Okay, Dr. Blatnik.
Okay, now I'm here. I was talking to myself.
Yeah, you're good.
Well, thanks for having me. I was really pleased to be involved with this last year and happy to be invited back again this year. We've got 20 questions we're going to try and get through here in the next half an hour to cover general abdomen, hernia, and spleen, and so we'll kind of move through. If there's a consensus on the answer, we'll just kind of blow by to try and get through everything. So our first question here is a 65-year-old person with who's 100 kilograms in the intensive care unit, intubated after being admitted with sepsis. He's received a large volume of intravenous fluid resuscitation, and his intra-abdominal pressure is measured via the bladder is 18 millimeters of mercury. He has a normal urine output and peak airway pressures. Are the following options which describes the most appropriate management for this patient? A, continued current management is 18 millimeters is a normal intra-abdominal pressure. B, reduce fluid administration and minimize enteral feedings. C, paralyze the patient. D, insert an intra-abdominal drain. Or E, decompressive laparotomy is 18 millimeters of mercury is indicative of grade 3 hypertension. So the answer to this is B, actually reduce fluid administration and minimize enteral feedings. So the takeaway for this is a couple things. Normal intra-abdominal pressure is considered 5 to 7, or in an obese patient such as this, it can be considered up to 15 millimeters of mercury. So 18 here is certainly a little bit above normal, but you want to take that into consideration. So at this point, you want to reduce your fluid administration and minimize enteral feedings. There's really no need at this point to paralyze the patient or do a decompressive laparotomy as he's still having normal urine output and peak airway pressures. So it is certainly elevated. You want to keep a close eye on it. And if it continues to go up, then that's when you consider some of those more aggressive options as time goes on. So question number 2, which of the following statements regarding preoperative splenic artery embolization is correct? A, the goal of preoperative splenic artery embolization is to facilitate easier identification of the splenic artery intraoperatively. B, the pancreatica magna must be embolized to ensure complete splenic artery embolization. C, successful splenic artery embolization results in about 80% of the splenic parenchyma becoming ischemic. D, microspheres or gelatin powder are used to embolize the splenic artery. Or E, splenic artery embolization is most useful during open splenectomy and adds little benefit to laparoscopic splenectomy. And so good. So C is the correct answer. So 66% of the people got it right. So just to briefly cover all the other things, it doesn't necessarily help you identify the splenic artery. They usually use small coils, which is the kind of the counteraction to letter C. But you usually can't feel those. As far as you want to try and preserve the pancreatica magna so you don't make the tail of the pancreas ischemic. Microspheres or gelatin powder do have a tendency to travel to other organs and can cause distal ischemia of other organs. And you can actually use this for both laparoscopic and open splenectomy. The one thing to keep in mind is you want to try to avoid stapling across some of the coils, as it can potentially lead to the stapler misfiring, and so that can be a problem as time goes on. But certainly C is the correct answer. 3, hereditary spherocytosis is the most common of the congenital hemolytic anemias. Which of the following statements is true concerning this condition? A, jaundice and biliary tract conditions are often the primary indication for surgery. B, the condition is transmitted as a sexual linked chromosomal abnormality. C, splenectomy should be performed at the time of diagnosis regardless of the patient's age. Or D, splenectomy corrects the condition such that spherocytes will no longer be seen on blood smear. So A is the correct answer. So jaundice and biliary tract conditions are often the primary indications for surgery. Hereditary spherocytosis is actually an autosomal dominant mutation, so it's actually seen in about 1 in 5,000 individuals. Splenectomy, it should actually be delayed until patients are older. So hereditary spherocytosis is often identified in young children. To try to minimize the risk for post-splenectomy sepsis, it should be delayed until after the children age some. And it actually does not remove the spherocytes. It just, they can still be seen on the blood smear, so it does not prevent that. But it is indicated for almost all patients with hereditary spherocytosis. Question number 4, testicular atrophy following inguinal herniorrhaplasty is usually due to A, thrombosis of the veins in the spermatic cord, B, subacute orchitis, C, damage to the external spermatic artery, D, ligation of the vas deferens, or E, damage to the testicle from mobilization. And thrombosis of the veins is the correct answer. That usually can happen during over-dissection. So if you're a little too aggressive during dissection of an indirect sac, you can damage these small veins, which leads to thrombosis, which can lead to venous insufficiency. It's a relatively rare complication, occurring really just in less than probably about 0.1% of primary repairs and up to 1% of recurrent repairs. That being said, I do always discuss it as a possibility in any of my recurrent inguinal hernias that I do with patients. But the thrombosis of the veins is much more likely to be the cause of testicular atrophy. Number 5, a 58-year-old chronic alcoholic has an umbilical hernia and ascites of recent onset. He's never been treated with the diuretics or salt restrictions. On examination, he has massive ascites with a large umbilical hernia with thin skin at the apex. There is a slow ooze of clear odorless fluid from the hernia. Therapy now should be sorry, I'll read them. Hernia repair with placement of a peritovenous shunt, umbilical hernia repair with prosthetic mesh, C, bed rest, intravenous antibiotics, aggressive medical diuresis and hernia repair during this admission, D, paracentesis and discharge, treatment with antibiotics and abdominal binder, or E, trial of strict diuretic regimen and salt restriction at home. So I think the key thing in this question is to take into account that there is a slow ooze of clear and odorless fluid from the hernia. It should really kind of guide your answer. That is correct. I think most people would agree that somebody who comes in with a large hernia and a large amount of ascites that's actively draining needs to be addressed during this admission. For this patient, he's never been treated with diuretics or salt restrictions, so that would be the appropriate first-line therapy. The antibiotics are there to try to minimize the risk for spontaneous bacterial peritonitis, and the rest of the answers are probably inappropriate at this stage of the game. A peritoneous shunt may be appropriate if he's failed attempts at medical management and comes in this situation, though. All right, next question. Are we able to go to the next question? There we go. An 82-year-old woman has abdominal pain, nausea, vomiting, and groin pain. Which of the following statements is true? A, pain upon extension and adduction followed by medial rotation of the thigh. Huship-Rumberg sign is frequently present. B, manual reduction should be attempted after conscious sedation. C, pelvic examination is likely to show a defect in the obturator canal. D, an inguinal approach to repair will require incision in the inguinal floor. Or E, the lateral aspect of the defect is bordered by the lacunar ligament. So a good mix of answers here. So the correct answer is actually D. So she has a femoral hernia is what they're trying to get at, which is most commonly seen in elderly females, which is what they kind of give you in the STEM. The takeaway from this is that you really should evaluate the intestine in this scenario. So she has nausea, vomiting, and groin pain, which would make you think that she has incarcerated bowel in there. So to just push it back in and ignore it is not the right answer. You can address these either open or laparoscopically, but you want to make sure you ultimately look at the intestine. So with an inguinal approach, you actually have to incise the inguinal floor to take a look at things. As far as the other answers, so a Huship-Romberg sign is frequently seen in obturator hernias, not femoral hernias. Manual reduction we talked about. Pelvic examination, not necessarily appropriate as it's not an obturator hernia. And the lateral aspect of the defect is actually the femoral vein. The lacunar ligament is more consistent with the medial border of the space. Number 7, which of the following statements about umbilical hernia repair is true? A, they're more common in men. B, incarceration is more common in women. C, spontaneous closure after delivery is the exception with pregnancy-associated umbilical hernias. D, elective repair is indicated in patients with ascites to prevent rupture of the skin. Or E, pediatric umbilical hernia should not be repaired until the child is 12 years old. So D is the correct answer. So most people agree that elective repair is indicated in patient with ascites to prevent the rupture of skin. As we kind of covered a couple questions ago, these are patients you want to make sure that are appropriately optimized medically with diuretics to try to minimize the risk for complications around the time of surgery, especially in an elective setting like this. It's actually 3 to 1 times more common in women. However, men are more likely to present with incarceration. Spontaneous closure after delivery is the standard. Most pregnancy-associated umbilical hernias were closed on their own. And pediatric umbilical hernias, most people say to wait until 5 years of age and then consider repair. Question number 8. After undergoing splenectomy for ITP, a patient has persistent disease concerning for missed accessory spleen. A technetium scan is ordered to localize it. Which is the most common location for an accessory spleen? And let's see if we can show the answers here. Good. So most people agree the hilar region is where it's most likely to be seen. So you can actually see accessory spleens in upwards of 15 to 30% of patients who present with ITP. The most common place that they are identified is the hilar region. The second most common would be in the vascular pedicle, and the third most common would be in the omentum. Number 9, a patient with an obturator hernia is most likely to present with A, dull pain in the lateral thigh, B, sharp pain in the perineum, C, pain on urination, D, hematuria, or E, bowel obstruction. So correct, bowel obstruction is the right answer. So these are a very rare form of inguinal hernias, accounting for really less than 0.1% of all hernias, which is what makes the diagnosis often difficult to make. The patient presents with oftentimes complaints of a bowel obstruction. Mortality from this has actually been very high because oftentimes the diagnosis is missed, and these patients tend to be of poor health. Sharp pain in the perineum isn't often seen, and dull pain is actually more likely in the medial thigh rather than the lateral thigh. Question number 10. ITP is a disease characterized by autoimmune destruction of platelets with clinical manifestations of thrombocytopenia and susceptibility to easy or excessive bleeding. Which of the following statements is true concerning ITP? A, the first-line treatment for ITP includes hydrosteroids, which will usually produce both an initial and sustained response with overall return of the platelet count to normal. B, acute ITP, which generally occurs in children following upper respiratory illness, should be considered an indication for splenectomy. C, the role of the spleen in ITP is both in the production of IgG antibodies to the platelet antigen as well as the primary site of platelet destruction. And D, splenectomy results in a durable cure for ITP in more than 90% of patients. So the correct answer is C. So the spleen in ITP actually is the production site for most of the antibodies and functions in platelet destruction. As far as letter A and D, so the first-line therapy is actually high-dose steroids, which also usually does produce an initial response, but it's rarely sustained. It's only seen to be sustained in like 15 to 25% of patients. And then as far as D, the splenectomy, the cure rate is closer to 70% rather than 90% of patients. So C is the correct answer. The most common hernia in females is a Spigelian hernia, B, femoral hernia, C, obturator hernia, D, indirect inguinal hernia, or E, direct inguinal hernia. So correct, indirect inguinal hernia is the most common. You know, everybody talks about femoral hernias occurring in females. That is true. If I were to give you a patient with a femoral hernia, it would be more likely to be in elderly women, but that doesn't necessarily mean all elderly women are likely to have femoral hernia. So indirect inguinal hernia is the most common hernia in females as well as in males. It can be 54% of all inguinal hernias in men, and up to 50% of all inguinal hernias in female are indirect inguinal hernias. Number 12, an indirect inguinal hernia is repaired laparoscopically by stapling polypropylene mesh over the defect. The complication of this repair, most frequently associated with significant postoperative pain, is A, formation of a hydrocele in the sac, B, recurrence of the hernia, C, erosion of the mesh into the intestines, D, entrapment of the ilioinguinal nerve, or E, entrapment of the lateral femoral cutaneous nerve. So E is the correct answer. So this is talking specifically about laparoscopic repair. In a laparoscopic repair, if you place a tack or a staple in the lateral portion of the mesh, where in an area you can't feel the tip of the tacker, that's where you're at high risk to injure the lateral femoral cutaneous nerve. The ilioinguinal nerve is very likely to be injured primarily in open repair. So that's a key thing to take away from this. Laparoscopic and open repairs have different nerves that are at most at play here. Number 13, a 25-year-old, 220-kilogram female presents to the emergency department with 3 hours of acute onset of right lower quadrant pain. She describes the pain as mild and reports persistent nausea and vomiting. There's moderate diffuse tenderness on exam, and laboratory studies reveal a white blood cell count of 17,000, a negative HCG. She is too heavy to fit onto the CT table. Which of the following diagnostic tests would be most helpful in finding the cause of this patient's abdominal pain? So diagnostic laparoscopy is the correct answer. You know, if you're unable to get a CT scan in a patient with a negative HCG and a white blood cell count of 17, most people would think that proceeding with laparoscopy will give you some better answers. With this kind of obesity, plain films and ultrasound are going to have limited effectiveness due to poor penetration and difficulty with the ultrasound getting through the fat. DPL is probably most useful in trauma. You know, 220 kilograms is 485 pounds. There certainly are CT scanners out there nowadays that can accommodate this, but we, you know, still run into patients who can't fit on the CT scanner, and this is something to take into consideration. Number 14, a 45-year-old man comes to your clinic for follow-up 1 month after an open inguinal hernia repair with mesh for an incarcerated left inguinal hernia. He endorses pain along the incision, and additionally the inside of his proximal thigh is numb, burns, or simply hurts when touched. When he moves in certain ways, he gets a stabbing pain in that area accompanied with a sensation of being stung by a bee. Which nerve is most likely causing this constellation of symptoms? So correct, ilioinguinal nerve is what they are describing here. So this is an area that's kind of affected by either sutures, mesh, or scar, and would provide symptoms along the inguinal ligament to the inner thigh and the medial groin. The genital branch of the genital femoral usually is the anterior scrotal skin in males or the mons pubis in females. The iliohypogastric gives you more burning pain along the incision laterally and down in the suprapubic region, and the obturator nerve in this case really isn't in play. But an obturator nerve injury would give you difficulty with ambulation and an unstable leg. Number 15, a 15-year-old boy presents to the emergency department with right lower quadrant pain, fevers, and a CT scan demonstrating evidence of perforated appendicitis with a 3-centimeter associated abscess. You relay the following plan to the patient's mother. Admit, place on IV antibiotics, and have interventional radiology place a drain in the associated abscess. The mother would like to know the risks and benefits of delayed operative intervention over just taking out his appendix during this admission. So C is the correct answer, so decreased postoperative complications. As far as what's associated with delayed therapy, I think at this stage with a 3-centimeter associated abscess, most surgeons agree that this is the most likely treatment, or the best treatment option would be drain and antibiotics and delayed operative interventions. You would actually likely get a longer hospital stay potentially, depending on kind of what you see. The abscess rate is already there. You're already addressing it. The rate for recurrent appendicitis is negligible, and the increased incidence of more extensive resection is possible, again, depending on kind of what the base of the appendix looks like and what you have to do. But overall decreased postoperative complications is more likely to be seen in a delayed intervention such as this. Number 16, the problem of overwhelming post-splenectomy sepsis is a significant concern. Which of the following statements is true regarding this consequence of splenectomy? A, the risk of post-splenectomy sepsis or septic episodes is essentially the same throughout life. B, the indications for splenectomy is not a factor in predicting the incidence of post-splenectomy sepsis. C, the risk of post-splenectomy sepsis is unrelated to age. Or D, the mortality rate of post-splenectomy sepsis is between 50 to 60% in most series. Correct. So the post-splenectomy sepsis rate of mortality is as high as 50 to 60%. The indication for splenectomy is a factor. For example, in patients who have splenectomy for trauma, the rate of post-splenectomy sepsis is about 1 to 2%, as opposed to patients with thalassemia, it can be as high as a quarter of the patients. And splenectomy sepsis is related to age, whereas children are much more likely to get it as opposed to older patients. Number 17, a 70-year-old male presents to the emergency department with an hour of acute onset epigastric pain. He has a history of diabetes, hypertension, and alcoholism. He has had persistent nausea and is tachycardic. Initial laboratory studies include a complete blood count, basic metabolic panel, and lipase, all of which were normal. Of the following tests, which should be ordered next to explain the etiology of his pain? So that's correct. So I think what they're trying to get you to take away is all patients who present with epigastric pain may not necessarily be having an intra-abdominal process. And this patient who's got a history of diabetes, hypertension, alcoholism, and 70 years old, you need to rule out other causes of epigastric pain, which could be cardiac or pulmonary, such as a pneumonia. He has a negative or normal CBC and basic metabolic panel as well as lipase. So I don't think there's a need to jump into EGD or right upper quadrant ultrasound or CT scan right away. I think the next best thing to do would be to get EKG and chest x-ray first. If those are negative, then you can consider some of these other options. Number 18, a 78-year-old man on postoperative day 6 after right hemicolectomy for colon cancer is found to have an increasing abdominal pain and an increasing white blood cell count. CT scan shows a 5 by 4 by 3 centimeter defined intra-abdominal fluid collection near the anastomosis. What is the next step in management? A, start ciproflagyl. B, percutaneous drain. C, return to the operating room and create a new primary anastomosis. D, return to the operating room and perform an open drainage of the fluid collection. Or E, return to the operating room and create an endoleostomy. So correct. The first line therapy here would be a play-to-place of percutaneous drain. He has an isolated, defined fluid collection. It is near the anastomosis, which makes you worried for a leak, but this is something that you want to place a percutaneous drain. The plan to return to the operating room would be most appropriate in somebody who's whether overall unstable or has more diffuse infection throughout their abdomen. Then that would be an indication for a return to the operating room. I got two more questions here in this section, so hopefully we'll get through it before we move on. Number 19, which of the following hematologic disorders is unlikely to respond to splenectomy? A, ITP, B, autoimmune hemolytic anemia, C, thalassemia, D, sideroblastic anemia, or E, hereditary spherocytosis. This is really just kind of a memorization question. So the correct answer is actually sideroblastic anemia, so that is least likely to respond to splenectomy. I think the takeaway here, splenectomy is indicated for diseases in which the blood cells, whether it's red blood cells or platelets, are destroyed or removed by the spleen. So in ITP, it's platelets. In autoimmune hemolytic anemia, it's red blood cells. Thalassemia and hereditary spherocytosis both can benefit from splenectomy. And 20, the last question, in this section, the most common complication of an inguinal hernia repair related to the herniorrhaphy itself is A, post-herniorrhaphy growing pain, B, infection, C, seroma, D, infertility, or E, recurrence. So growing pain is the correct answer here. In certain series that you can see over half of patients after open inguinal hernia can have some form of growing pain. Obviously, there's a wide range of minimal, mild discomfort to lifestyle-limiting growing pain, and that certainly plays an effect here. Seroma, you can see it's not probably the most common necessarily complication as far as percentage-wise, and with the advent of mesh-based repair, recurrence rate has fallen away as probably the most common complication that we see. So I think that wraps it up for this section. I think we're going to move on, and I'll let Dr. Awad introduce our next speaker. Thanks again for the opportunity, and good luck, everybody.
Dr. Blatnik, thank you very much. That was wonderful. Really appreciate it. And I'd like to introduce our next speaker, Dr. Amber Traugott. Really a pleasure to have Dr. Traugott joining us today. She is a colorectal surgeon at Ohio State University and will be leading us through the discussion of colorectal and anal disease ABSITE questions. Welcome very much, Amber. Good you can join us.
Hi, thanks, Dr. Awad, for inviting me to participate. I want to apologize a little bit in advance for the quality of my voice tonight, but if anybody has any difficulty understanding me, please just type something in the chat box and I'll try to address it. So the first question, a 65-year-old man has mucus discharge and perianal discomfort. Physical exam reveals a fistulous opening lateral to the anus. Endoscopic examination allows passage of a probe through the fistula tract. The fistula traverses the internal anal sphincter, the intersphincteric plane, and a portion of the external anal sphincter. The fistula is characterized as which type? And choices are there: transsphincteric, extrasphincteric, intersphincteric, or suprasphincteric. Okay, so most people got this right. An intersphincteric fistula, looks like about a quarter of you answered that. An intersphincteric fistula implies that the fistula tract does not involve any of the external sphincter. It only crosses the internal sphincter, and the external opening would be in the intersphincteric groove, which would be right outside the anal verge. And so that's what that classification refers to. Transsphincteric refers to any involvement of the external sphincter where it's crossing the intersphincteric plane. Extrasphincteric and suprasphincteric fistulas are either crossing the levator ani in the case of extrasphincteric fistulas, where suprasphincteric fistulas have extension in the intersphincteric plane all the way above the puborectalis before they cross the levator ani. Next question. A 55-year-old woman is referred by a GP because of bleeding hemorrhoids. Proctoscopic examination reveals a brownish, non-ulcerated polypoid lesion, 1.5 centimeters in diameter in the anal canal and 2 centimeters above the dentate line. Intrarectal ultrasound shows the depth of invasion into the submucosa and no enlarged perirectal lymph nodes. There is no inguinal lymphadenopathy, and the patient has good continence. Biopsy shows melanoma. Which of the following is true? Another option for treatment is immunotherapy. Anal canal is the most common site of melanoma. Preoperative chemoradiation followed by wide local excision is the best treatment, or the treatment of choice is wide, full-thickness local excision. Okay, so most of you are correct. The treatment of choice is full-thickness local excision. And the reason for that, as opposed to radical excision, is that the survival rates are no better with the radical excision versus local. Now, as far as neoadjuvant treatment, melanoma is unlike adenocarcinoma in that it doesn't really respond well to traditional chemoradiation therapies. And so there's really not much role for those in the case of a well-defined melanoma that doesn't have any evidence of metastasis. The other options are not many of you chose, so we'll go on to the next question. Number 3, regarding appendiceal carcinoid tumors with hepatic metastases, the following is true. A patient with liver metastasis from an appendiceal carcinoid has a 5-year survival of less than 20%. B, liver metastases should always be debulked if the patient has adequate functional status and is a reasonable operative candidate. C, hepatic resection is not recommended as a method of tumor debulking in symptomatic liver metastases. D, hepatic artery embolization is usually ineffective because carcinoid tumors derive the majority of their blood supply from the portal venous system. And E, despite extensive hepatic metastases, 5 and 10-year survival rates are quite favorable in carcinoid tumors. Okay, so almost half of you got the correct answer. So carcinoid tumors, even when they're widely metastatic, tend to grow in a rather indolent fashion, even if they're causing symptoms. The next most popular choice was that liver metastases should always be debulked. Always is kind of a strong statement. Usually when patients have metastatic liver disease, we kind of engage in multimodality therapy in treating them, and that could be anything from treating with octreotide for symptomatic control to doing local therapies on the liver, such as embolization therapies, or in some cases resection. And then, as we talked about, the 5-year survival is actually quite favorable, so A is not correct. Number 4. A 52-year-old man without symptoms is undergoing screening sigmoidoscopy. A 2-centimeter yellow submucosal nodule is found in the rectum 6 centimeters from the anal verge. Findings at deep endoscopic biopsy suggest carcinoid. Appropriate management includes which of the following? LAR, transanal excision, APR, or observation. Okay, so the correct answer is transanal excision. And this is something, when you're thinking about carcinoids, Size is everything when you're taking these exam questions, when you're looking at patients with these. So 2 centimeters is kind of the cutoff where local excision may be appropriate. Over 2 centimeters, the rate of metastasis is rather high. So in those cases, whether it's in the appendix or in the rectum, we would tend to recommend a more radical resection similar to what you would do for an adenocarcinoma. But up to 2 centimeters, as long as there's no findings concerning for metastasis, local excision is appropriate. So that's the reason why LAR and APR are not appropriate. Number 5, a 63-year-old woman with microcytic hyperchromic anemia, occult blood in the stool, and a weight loss of 10 pounds is found to have bilateral ovarian enlargement on initial physical examination. The most likely diagnosis is A, multiple myeloma with colon mucosal involvement, B, a GI tract malignancy with Krukenberg's tumors, C, a primary ovarian malignancy metastatic to the colon, D, endometriosis, or E, endometrial carcinoma with colon invasion. That's correct, and most of you got that correct. And really the key there is that it's bilateral, which makes Krukenberg tumor much more likely. Number 6, a colonoscopy for rectal bleeding. A 45-year-old man has a 1 centimeter submucosal lesion of the rectum. The biopsy diagnosis is granular cell myoblastoma. Appropriate management would be A, radiotherapy, followed by wide local excision, B, ciliotomy with wide local excision, C, laparoscopic excision, D, LAR, or E, colonoscopic excision. So E is correct, colonoscopic excision. Pardon me.
Dr. Traugott, or would you
Yeah.
prefer I read the questions and answers and you just do the discussion part?
That would be great.
Okay, why don't you finish what you're saying and I can start with the next one. Thank you so much.
Sure. So granular cell myoblastoma is kind of an old term for what we now call granular cell tumors, most of which are benign unless they have atypical features. And so endoscopic excision is appropriate for those as long as they're small enough to be done safely by that approach.
Okay, I'll help with the reading part, but I'm going to definitely need your help for the discussion. So let's, let's start. Number 7, a 65-year-old man presents to the emergency department with 2 months of increased abdominal fullness, constipation, and change in stool. He has no prior surgical history and had a colonoscopy 12 years ago, which was normal. Vitals are normal. He's a little distended, but no rebound or guarding. On rectal exam, you can palpate a firm mass 3 centimeters from the anal verge. The biopsy reveals rectal cancer. You attempt endorectal ultrasound, but you cannot traverse the mass. What's the next best step? Neoadjuvant chemoradiation, endoscopic stenting, exploratory laparotomy and colostomy in Hartmann's pouch, or APR with end colostomy, or LAR with diverting loop ileostomy.
I think part of the question didn't make it onto the slide.
Yeah.
An MRI shows it's a T3 rectal cancer.
Oh, thank you, Dr. Traugott.
So correct. Neoadjuvant chemoradiation is appropriate for locally advanced rectal cancer, which is T3 or above.
Okay, number 8, which of the following statements regarding surgical management of rectal cancer is true? A, total mesorectal excision is only required for T4 rectal tumors. B, resection margins should be a minimum of 3 centimeters from the tumor edge. C, in low rectal cancer, the distal margin should be a minimum of 1 centimeter from the tumor edge. D, surgical excision should be timed for 1 to 2 weeks following completion of neoadjuvant chemoradiation. Or E, when compared to LAR, APR is associated with improved survival and decreased local recurrence rates for mid and low rectal cancers. Oh, oh, sorry about that.
Okay.
Apologize. We had a technical difficulty there.
Well, I briefly saw that about half of people had selected the correct answer, which for this question is in low rectal cancer, the distal margin should be a minimum of 1 centimeter from the tumor edge. Now that's true for very low rectal cancers, but in general, if it's a mid to high rectal cancer, we aim to get a margin of 5 centimeters if possible. 1 centimeter is kind of the minimum necessary, and only when you're trying to do a sphincter sparing operation. I'm not sure what other options were chosen by the respondents, but APR is not associated with improved survival or decreased local recurrence in mid and low rectal cancers. Now that's all based on retrospective data, so you would think that they would be doing a more radical resection for a tumor with worse biology, but that's what the data shows that we have.
And Dr. Traugott, apologize, we're just bringing the PowerPoint back online. If you have the question written, perhaps you could just read it, and while we're bringing this up.
Sure. The next question is a 25-year-old man has a 3-centimeter perianal abscess that has lasted approximately 4 days. The patient has otherwise been in good health. There is no history of diabetes. Which of the following statements is true? A, unroofing the fistula or fistulotomy is the basic management of anal fistula if the external sphincter is not involved. B, fistulectomy is the best management of fistula to avoid recurrence. C, antibiotic therapy for 7 days is needed. And D, a subsequent anal fistula, if deep, should be managed with a diverting colostomy as a first stage. You can mull over that for a minute. And while we're waiting, I think I'll just go over the answer to that one. So unroofing a fistula or performing a fistulotomy is the appropriate treatment as long as the external sphincter is not involved. Now that comes with a caveat, where if you're dealing with a patient with an intersphincteric fistula who already has problems with incontinence, you may want to consider another therapy in that situation. But for most straightforward fistulas, it's fine to do a fistulotomy for an intersphincteric fistula. All right, well, next question. A patient presents to you for your surgical evaluation of a recently diagnosed adenocarcinoma of the descending colon diagnosed on flexible sigmoidoscopy. What is the next appropriate step in management? A, schedule a left hemicolectomy in the next 3 to 4 weeks. B, refer to oncology for neoadjuvant chemo. C, endoscopic ultrasound to determine stage. D, preoperative colonoscopy to assess for a synchronous lesion. Or E, repeat flex sig to confirm the diagnosis. Let's see if we can find that slide.
Okay. Dr. Traugott, I think we're back online.
Okay.
Are you able to see me?
Yep.
Okay, great. And what question were you on just now?
We're on question 10.
Okay. There it is. And you finished reading it?
I did.
Okay. Oh, folks get a chance to apologize, everybody, for the technical difficulties there. We had a brief shutdown, but we are back.
So that's correct. If the patient was diagnosed only with a flexible sigmoidoscopy, you've not completed your assessment to look for any synchronous lesions, which can occur at a rate of about 3 to 5%. An endoscopic ultrasound really couldn't be performed easily at that location. The preoperative staging for colon cancer is usually done by CT to look for metastatic disease.
Okay, I can continue reading if you'd like.
Sure.
Okay, number 11, which of the following is correct regarding diagnosis and management of appendiceal masses? A 2.5 centimeter carcinoid tumor of the tip of the appendix should be managed by appendectomy alone. B, a 1 centimeter carcinoid tumor located at the base of the appendix is appropriately treated with appendectomy alone. C, tumors greater than 2 centimeters in diameter are associated with a 15% chance of nodal or distal metastases. D, carcinoid tumor with a negative margin, no evidence of lymphovascular invasion, and with some associated mucin production should undergo hemicolectomy. Or E, carcinoid is the second most common appendiceal mass.
Okay, let's talk about this one. So the correct answer was B. And the reason for that is that you're looking for risk factors for metastasis that would prompt you to perform a more radical resection. So in this case, lymphovascular invasion would be a risk factor. It's not present. But mucin production is also a risk factor. And so if there was mucin, you would want to perform a hemicolectomy. Now, most of you answered that tumors greater than 2 centimeters are associated with a 15% chance of nodal or distal metastases. It's actually closer to 30 to 60%. So that's why we do radical resections in those patients. As far as how common carcinoid is, it's actually the most common appendiceal mass, even though appendiceal masses in general are terribly common. And with regards to the other two, it's all about the location and the size.
Okay, number 12. A pedunculated polyp found incidentally at colonoscopy is removed by means of snare polypectomy from the ascending colon. Invasive cancer to the level of the submucosa is identified histologically within the polyp. The lesion is well differentiated. No lymphatic or vascular invasion is found. The cauterized margin does not contain neoplasia. Appropriate subsequent management includes which of the following? A, repeat endoscopy with fulguration of the polypectomy site. B, subtotal colectomy, C, endoscopy in 6 months, or D, right hemicolectomy.
So that's correct. Endoscopy in 6 months is the appropriate management. And that's because the invasion does not go through the submucosa, and there was not an invasive disease found at the margin of the polypectomy. Right hemicolectomy would be appropriate if it were more deeply invasive or if the margin was not negative.
Number 13. A 25-year-old woman gave birth 1 month ago. A midline episiostomy became infected. The wound has now completely healed with no residual infection, but the patient passes gas and stool into the vagina. Examination reveals a 2 millimeter rectovaginal fistula at the level of the dentate line anteriorly. Which of the following statements is true? A, start antibiotics and continue for 2 weeks. B, endorectal advancement, anorectal flap repair gives satisfactory results. C, the patient needs a permanent colostomy. Or D, fistula repair should be immediate.
So that's correct. an endorectal advancement flap gives satisfactory results. However, you want to wait about 3 to 6 months before undertaking this to allow some inflammation to subside, and about half of them will heal on their own without any intervention. So you want to give the patient a chance to resolve the problem before you intervene.
Number 14, 2 years after a sigmoid colectomy for stage 3 at T3N1M0 carcinoma of the colon, a 55-year-old man has a solitary 2-centimeter metastasis in the periphery of the right lobe of the liver. The most appropriate management is A. Infusion of 5-fluorouracil via the hepatic artery, B. Wedge resection of the lesion, C. Right hepatic lobectomy, D. Ligation of the right hepatic artery, or E. External beam radiation therapy.
So good, wedge resection is appropriate. A right lobectomy is not necessary in the case of a peripherally located lesion where adequate margins can be done with a non-anatomic resection.
Number 15. Which of the following types of colonic polyps is associated with the highest incidence of malignant degeneration? A. Tubular adenoma, B. Villus adenoma, C. Hamartomatous polyp, or D. Tubulovillus adenoma?
Right, so this is mostly a memorization question. Villus adenomas have the highest rate of malignancy associated with them, up to 40%. Tubulovillus adenomas are more common, but their rate is only about 22%.
Number 16, a 60-year-old man with a history of several bouts of mild sigmoid diverticulitis has had increasing abdominal pain and fever for 5 days. Examination reveals diffuse abdominal tenderness that is worse in the left lower quadrant. CT scan shows an abscess in the left gutter, moderate amounts of free fluid, and free air in the peritoneal cavity. In addition to broad-spectrum antibiotics, the most appropriate treatment strategy would be to A. Drain the abscesses in 36 hours if the patient does not improve. B. Drain the abscess percutaneously. C. Perform laparoscopic transverse colostomy and drain the abscess percutaneously. D. Resect the sigmoid colon, search for additional abscesses, drain the gutter abscess, and perform descending colostomy with the oversew of distal segment. Or E. Resect the sigmoid colon and reestablish intestinal continuity.
All right, so this is correct. So this is a patient that has at least Hinchey 3 diverticulitis. So he has free air and he has abdominal examination findings that are concerning. And for that reason, he's not a candidate for a local percutaneous procedure.
Number 17, which of the following is most predictive of perforated appendicitis? That is, which of these are most associated with perforated appendicitis? A, younger age, B, white blood cell count greater than 10,000, C, tenderness at McBurney's point, D, female sex, or E, more than 3 comorbidities.
That's correct. Other factors include older age, male patients, or poor socioeconomic or poor insurance status.
And the white blood cell count, I think, is associated with acute appendicitis, but not necessarily that it is
with perforation. That's correct.
Number 18, A 20-year-old man visits your office because he has had anal pain during and after bowel movements for more than 2 months. There's also bright red blood on wiping. There is no problem with diarrhea or abdominal cramps. Examination of the anal canal reveals a 5 by 5 millimeter deep anal fissure in the posterior midline of the anus. Which of the following is true? A. The unhealed fissure is caused by repeated trauma from bowel movements. B. Lateral sphincterotomy is effective but can result in decreased continence to stool. C. Nitroglycerin paste increases anal resting pressure. Or D. The triad of anal fissure consists of fissure, sentinel skin tag, and internal hemorrhoid.
Okay, good. The correct answer is B. A is not correct because although a difficult bowel movement can precipitate formation of a fissure, it fails to heal due to local ischemia due to poor blood flow due to hypertonic internal sphincter, which is why our treatments focus on weakening that sphincter to allow better blood flow to the fissure site.
Number 19. The most common complication after hemorrhoidectomy is which? Wound infection, incontinence, rectal bleeding, or urinary retention.
Correct. So urinary retention is more common than rectal bleeding. Tends to be associated with aggressive fluid resuscitation or aggressive infiltration of local anesthetic. If it presents late, you must be aware that that can be a sign of deep space infection.
All right, and our final question in the colon anorectal section is, which of the following statements about colorectal carcinoma associated with Crohn's disease is true? A. Frequency of carcinoma is similar in patients with extensive long-standing unresected Crohn's colitis and those with extensive ulcerative colitis. B. It usually occurs in women. C. The right colon is involved in over 70% of patients. D. The occurrence of carcinoma is unrelated to the duration of Crohn's disease. And E. The mean age of patients with colorectal carcinoma is 35.
All right, so A is correct. When you're talking about patients with extensive long-standing disease, the cancer rates are similar between Crohn's and UC. The left colon is actually more commonly involved than the right colon.
All right, and that concludes our colon and anorectal disease section. Dr. Traugott, thank you so much for joining us today. We wish you good health and hope you feel better soon.
Thank you.
All right. All right, and the final section of today is small intestine biliary disease and flexible endoscopy. This section is often thought to be one of the harder ones on the ABSITE, so we hope you all can continue to join us for this, as this is a critical section. We are very, very fortunate to have Dr. Adnan Alseidi here from Virginia Mason. Dr. Alseidi, welcome, and thank you for being here.
No, thanks for having me, Mike. Appreciate it.
All right. I'll let you go ahead. Maybe
Okay.
you can, yeah.
Perfect. So first question is about a biliary injury. Its management of suspected bile duct injury depends on a number of factors. Most importantly are the mode and timing of presentation, which of the following statements is true concerning a patient with a suspected bile leak after laparoscopic cholecystectomy. A is cholangiography and placement of a percutaneous transhepatic biliary catheter to control of the fistula should be the initial step. B is the patient should be discharged home to allow the leak to close spontaneously. C is surgical placed drains should be removed to allow the fistula to close. And D is laparotomy should be performed immediately. Excellent. So most of you answered that correctly. The key here is to get source or sepsis control, abdominal sepsis control. Going to the operating room, the last one is not wrong. If you think somebody's got biliary peritonitis and the only way to control that is to go in and to wash that laparoscopically and place drains. But in general, we try to do the lesser invasive step and getting this controlled with either percutaneous drains plus a PTBD or a percutaneous biloma drain alone is the way to go. So certainly most people got that. So the second question is a 28-year-old woman with Crohn's disease has had 3 prior bowel resections, including an ileocectomy. She has signs and symptoms of high-grade partial small bowel obstruction that do not resolve with NG tubes, corticosteroids, and total TPN. At exploration, she has 3 strictures, one at the ileocecostomy and the others 30 and 50 centimeters proximal to the first. Her entire length of small bowel is 110 centimeters from the ligament of Treitz to the ileocolostomy. The best, and then it's erased there.
The best management now.
Best management now would be one of the following. A is local injection of corticosteroids. B is 3 strictureplasties. C is a single resection removing all 3 strictures. Next number D is 3 separate resections and anastomoses. And then E is resection of the ileocolic stricture and a balloon dilatation of the proximal 2 strictures. Okay, the majority got that correct as well. The answer is 3 strictureplasties. The idea here is that you want to minimize, maximize the amount of bowel in continuity that you leave behind. Generally, we think 100 centimeters is really kind of the minimum to avoid short gut syndrome. In this patient, they really doing one resection include all 3 is not an option. They're spread really all over. The last one, some 30% answered that, and doing balloon dilatations on these strictures that are that far out is rather challenging and actually will have a higher rate of recurrence than strictureplasties. So while in general using a balloon intraoperatively is ideal to find a stricture or to confirm that a stricture is there, but once you find one, a strictureplasty is the way to go. Local injections really has no, it basically fell out of favor at this point, and we discussed the other 2. The next question is, which of the following statements is correct with regards to irritable bowel syndrome? A favorite question here. So A is there is a 3-to-1 male to female predominance. B is peak incidence is in the 2nd through 5th decade. C is diagnosis is made via transanal biopsy. D is IBS is associated with non-specific mucosal inflammation. Okay, again, most of you got it correctly. It is B. Peak incidence is between 2nd to 5th decade. The number 1, sorry, A is incorrect because it's about a 2 to 1 predominance. C, there's no biopsy for IBS. And then 3, with respect to inflammation, same thing. It's incorrect in the sense that no single test really diagnoses IBS. It's more of a diagnosis of the presence of nonspecific symptoms in the absence of disease or organic disease or biopsyable disease. So answer here is B. The next question is, during cholecystectomy, an intraoperative cholangiogram shows opacification that terminates in the distal column bile duct with no entrance of dye into the duodenum. All of the following are appropriate options to proceed, except A, administer 1 milligram of glucagon intravenously and repeat cholangiogram. B, proceed with laparoscopic common bile duct exploration through the cystic duct using a choledocoscope and or a basket retrieval device with fluoroscopy. C is complete the cholecystectomy. D is convert to open and perform a common bile duct exploration. E is leave a feeding tube in the cystic duct, exteriorizing it for drainage of bile and perform a postoperative ERCP. Okay, so C is correct that you do not, remember this is an accept question, want to complete the cholecystectomy. In general, you do not continue with the cholecystectomy if you have an abnormal intraoperative cholangiogram. In this case, it's abnormal because you don't have flow into the duodenum, and so at this point you don't really know if you have to assume that there's common bile duct stones, but you also don't know that if you have any abnormal anatomy, you don't have a complete cholangiogram, and in general you don't want to proceed, and all the other ones are correct depending on where you are. If you're doing glucagon is easy, you can probably do that anywhere. If you're in a setting where you can do a laparoscopic common bile duct exploration, that is certainly an appropriate thing to do. If you're not and you're uncomfortable doing an open common bile duct exploration, that is also an appropriate thing to do. If you're not and you want to transfer this person out and you're worried that they may have a common bile duct obstruction with a stone, and that they may be at a risk for cholangitis, a very good option is to leave that same catheter you use for the IOC or a pediatric feeding tube through in the cystic duct as your drain, and transfer that patient for an ERCP. That is unnecessary if you're in a setting where you can get an ERCP the next day or something like that. Next question, is an 80-year-old female returned to the emergency department on a post-operative day 5 after laparoscopic feeding jejunostomy placement. Her feeding jejunostomy tube fell out at her nursing facility approximately 2 hours prior to her arrival at your ER. What is your first course of action? A is admit patient to the hospital with a plan for elective tube replacement in the operating room the following day. B, take the patient to the operating room for immersion tube replacement. C, attempt to replace the jejunostomy tube at the bedside. D is consult IR for tube placement under fluoroscopy guidance. And then E is obtain an upright abdominal x-ray. Okay, so we've got all kinds of answers here. So let's discuss them a little bit. So the correct answer is attempt to replace the jejunostomy tube at the bedside. And the reason why is because of the timing. The key here is to keep in mind that the question is asking post-operative day 5. So in day 5, you're still worried about that your bowel is not adhered to the abdominal wall and the tube falls out, put that patient at risk for an open enterotomy, if you will, in the abdomen. If you can place the catheter at the bedside and it goes down easily, and then you do a gastrographin study and it shows that it's in the bowel, then you've basically solved the problem. And often that actually can be done very easily, especially that she's presented 2 hours after it fell out. If you can't place a catheter because you try and it just doesn't go anywhere, or you do it and you inject gastrographin and it's in the peritoneum, then obviously the patient needs to go to the operating room for exploration and replacing this tube, because at this point you have to assume that they have an open enterotomy. So going over each one of these in detail, so admit the patient and wait till the next day. That's not ideal for a patient who the feeding tube falls out prior to day 10. Usually 10 days is kind of the cutoff. After 10 days, it's okay to wait and do this selectively. Number 2 is taking patients emergently to the operating room. That's what you would do if you're unable to place this feeding tube at the bedside and confirm that it's in the bowel. But if you're able to do that, you save them going to the operating room. C is the correct answer. D, consult the IR, which again we just discussed. You could do this at the bedside. And then the last question is not wrong. It's just that it's not the best answer in the sense that typically if you put the catheter in, whatever the X-ray shows you, you're still going to try to put the catheter in at the bedside, and that's probably why C is the right answer. 6 is a young patient undergoes an ileocecectomy resection for Crohn's disease complicated by obstruction. The site at highest risk for recurrence of Crohn's disease is sigmoid colon, next is rectum, next is ileum proximal to the anastomosis, and next is colon distal to the anastomosis. So the answer C is correct, that the most common site of recurrence is usually at the anastomosis or just proximal to the anastomosis. So there's a note on the chat room here about the G-tube may cause replacing the G-tube at the bedside may cause possible injury. And the whole idea here is that you're basically putting in usually a Foley catheter or a lubricated small G-tube. And even if you have a false passage, you will know, and certainly shouldn't cause an injury to the bowel. It's just a matter of basically whether it goes easily or not. Let's look at the next question. I'm going to go a little faster because we're running a little behind, but certainly slow me down by using the chat room if needed, please. The next question is, an ampulectomy is least likely to be indicated for which one of the following? A is 2 centimeter villus adenoma. B is 2 centimeter gastronoma. C is carcinoid less than 3 centimeters in diameter. D is adenocarcinoma of the ampulla less than 3 centimeters in diameter. And E is adenomatous polyp. So the correct answer is actually D, which is adenocarcinoma of the ampulla, less than 3 centimeters. Remember that ampulectomy is a resection that's typically not done for cancers. And all of these at this point are not cancers except D, which is adenocarcinoma of the ampulla. So for adenocarcinoma of the ampulla, we treat these because they're malignant. We treat this with a pancreatic duodenectomy as opposed to the other ones, which you don't actually know. Adenomatous polyp might have cancer, so you can actually start with an ampulectomy, but if it shows cancer, you would actually have to do a pancreatic duodenectomy. But doing an ampulectomy would be acceptable for E, so the answer is D. The next one is an 80-year-old female remains intubated after aortic valve replacement due to her history of severe COPD. On postoperative day 5, she develops a temperature of 38.6, pulse is 119, the white blood count is 14,000. Right upper quadrant ultrasound demonstrates perihepatic fluid and a defect in the gallbladder wall. What is the recommended treatment? A is intravenous antibiotics, broad spectrum. B is percutaneous cholecystostomy tube and intravenous antibiotics. C is early cholecystectomy and intravenous antibiotics. D is transpapillary endoscopic drainage of gallbladder. And then E is percutaneous abscess drainage and intravenous antibiotics. So I figured that this would be a challenging question. The answer is early cystectomy, cholecystectomy, and intravenous antibiotics. And the key is how the question is asked. I think what most people answered percutaneous cholecystostomy too, because the idea here is what happens if you have somebody with acalculous cholecystitis or even calculous cholecystitis and they're sick, like this person. In that setting, yes, correct. The answer is you do the least invasive way to get source control, which is a transhepatic percutaneous cholecystostomy tube and antibiotics, and then when they're better and electively take out the gallbladder. But that's not this case. This case is a person with gangrenous perforated cholecystitis, acalculous cholecystitis, as seen by the ultrasound showing pericholecystic fluid and a defect in the gallbladder wall. And in those settings, that pericholecystostomy tube is not going to be as effective, and early cholecystectomy is recommended despite the fact that she's actually intubated and sick.
I think the key in that one is the defect in the gallbladder wall with the gallbladder ischemia is the indication for surgery there.
Right. Okay, which one of the following statements is true concerning natural history of gallstones? Approximately 10% of asymptomatic patients annually become symptomatic per year. B is complicated gallstone disease develops in less than 5% of symptomatic patients per year. C is most patients with gallstones are symptomatic. D is approximately 25% of patients with complicated gallstone disease have no prior symptoms. Yeah, so this is basically understanding the numbers, really. I mean, it's kind of a question of natural history. In general, approximately 1 to 2% of asymptomatic individuals with gallstones will develop serious symptoms or complications related to the gallstones per year. So 1 to 2%. So the answer is actually B, which is complicated gallstone disease develops in less than 5% of symptomatic patients per year. Remember that 20 to 30% of patients with gallstones will become symptomatic over 20 years. So the vast majority are asymptomatic. And so that's why C is wrong, and that's why D is wrong. So the two numbers to remember is 20 to 30% will become symptomatic over a couple of decades, like over 20 years. 20 to 30% will become symptomatic, and 1 to 2% of asymptomatic gallstones will develop serious complications. A 45-year-old man with a history of previous right hemicolectomy for colon cancer has developed colicky abdominal pain that has become constant over the last few hours. He has marked abdominal distension and has only minimal vomiting of feculent material. His abdomen is diffusely tender. A radiograph of the abdomen shows multiple air fluid levels with dilation of some loops to greater than 3 centimeters in diameter. The most likely diagnosis is A, distal small bowel obstruction, B, proximal small bowel obstruction, C is closed loop small bowel obstruction, and D is acute appendicitis. So correct answer is distal small bowel obstruction. Third said closed loop obstruction. In general, closed loop obstruction, you would see more symptoms of severe pain and signs of peritoneal irritation more than distension and vomiting. Vomiting can happen, but usually you don't see patients severely distended with multiple air fluid levels as described here in either proximal small bowel obstruction or closed loop small bowel obstruction. And thus distal small bowel obstruction is the correct answer, or most likely answer, I should say. Number 11 is actually the same question. However, the stem has the last active part of the stem is different, which is which of the following statement is true concerning laboratory tests that may be obtained for such a patient. A is there is no reliable, readily available test to differentiate tissue necrosis from simple bowel obstruction. B is the presence of white blood count greater than 15,000 would be highly suggestive of closed-loop obstruction. C is metabolic acidosis mandates emergency exploration, and D is an evaluation of the BUN level suggests underlying renal dysfunction. Yeah, so that's correct. The vast majority got that in the sense that there's really no best, I mean, all of these things that you look at, A is correct in the sense that all of these things that you look at, white blood count, acidosis, tachycardia, sepsis, picture of sepsis, tenderness, all will make you more concerned about strangulation, but there isn't one laboratory test or a laboratory test that we think is very specific to say this is strangulation versus obstruction. So it's a clinical picture, the entire clinical picture. Okay, 12 is a 44-year-old woman has obstructive jaundice caused by mid-bile duct stricture 4 months after a laparoscopic cholecystectomy. Which of the following statements is true for this patient? A, surgical resection offers a better chance of long-term success than either percutaneous or endoscopic dilatation. B, the success rate at 5 years following surgical reconstruction is 50%. C is both endoscopic and percutaneous balloon dilatation can be completed in a single operative session. And D is surgical reconstruction is the only option for treatment of this patient. So the answer is A, that a surgical reconstruction is the best option. The third answered both endoscopic and percutaneous can be done in single session. In general, we don't recommend that. When patients have jaundice, the first session is usually just to put a stent in and to relieve the jaundice, and then the second session is to do the dilatation. And the reason why is when you go in the first time and you relieve obstruction, a significant number of these patients will have a profound SIRS response, and you don't want to manipulate them even further. So in general, we recommend multiple sessions, and even in multiple sessions, the recurrence rates are higher than surgical repair. And surgical repair in a patient like this will have a long-term patency upwards of 90%. Because of the fact that this was depending on whether this was a thermal injury, a clip injury, but nevertheless it should be anywhere from 70 to 90% long-term patency. So. 13, the principal goal of surgical intervention in an infant with pneumatosis intestinalis is in the setting of necrotizing enterocolitis are to remove gangrenous bowel and preserve intestinal length. Which of the following is not an indication for operative intervention? A, presence of pneumoperitoneum. B is positive paracentesis. C is abdominal erythema. D is portovenous gas. And E is extensive pneumatosis. So the answer is E, extensive pneumatosis. This is certainly outside my clinical purview, but in general, the only hard indication to go to the operating room is the presence of pneumoperitoneum, and everything else is still a very strong indication based on the whole big clinical picture. Extensive pneumatosis in itself is not something that is considered a direct intervention to go to the operating room, and sometimes that's treated medically as well. 14, a 60-year-old man has weight loss and abdominal pain. Assessment includes an EGD and a CT scan demonstrating an adenocarcinoma of the third portion of the duodenum with enlarged portohepatis and celiac nodes, but no evidence of non-nodal metastasis. The most appropriate management of this patient would be A, non-operative palliative management, B, palliative duodenal bypass, C, segmental duodenal resection and regional lymphadenectomy, D is simple segmental duodenal resection, and E is pancreaticoduodenectomy. So this is a little bit of a challenging question. The answer is actually C, which is segmental duodenal resection. Many people confuse duodenal cancer with pancreas cancer in terms of treatments. For duodenal cancer, duodenal cancer in duodenal 1 or 2, in the first or second part of duodenum, generally we treat with a pancreaticoduodenectomy. In the third or fourth portion of the duodenum, we treat these with a duodenal resection and lymphadenectomy. In patients also that have pancreatic cancer, celiac access lymph nodes considered metastatic. In duodenal cancer, it's not. Overall, duodenal cancer is much more favorable than pancreas cancer. It's thought to be probably even a little more favorable than ampullary cancer, but the surgical treatment is a little different. So the answer is C again. The next question is the incidence of recurrent pancreatitis or other gallstone-related complications during the 6-week period following an episode of gallstone pancreatitis in a patient who do not undergo cholecystectomy is 0, B, 5%, C, 25%, D, 50%, E, 100%. Asking during 6-week period. Correct. So the answer is 25%, which is C. In general, most patients will have recurrent symptoms within 2 to 3 weeks. 25% of patients will have recurrent symptoms within 2 to 3 weeks. So within a 6-week period, the answer is 25%. Which of the following is a risk factor for development of bile duct cancer? A, estrogen administration, B, smoking, C is primary sclerosing cholangitis, and D is Crohn's disease. PSC is the correct answer. That and colorectal cysts are probably the two things you'll see in the test. And probably smoking increases the risk of everything, but I'm not sure that it's directly linked to cholangiocarcinoma. 17 is a 32-year-old biotech executive, has low-grade fevers and intermittent low abdominal pain. A radiologic workup shows a 10-centimeter narrowing of distal ileum and cobblestone changes of the mucosa in that area. The most appropriate maintenance therapy is A, ileocecal bypass, B, administration of Remicade, C is ileocolic resection, D, administration of prednisone, E is ileoresection. So the answer is actually administration of prednisone. This is basically a picture of a patient presented with Crohn's disease, and obviously save patients that present with either cancer or free perforation, medical management precedes surgical management. And in general, TNF inhibitors like Remicade are reserved for patients who failed steroids. So in general, prednisone will be the first line. 18, reproduction of biliary colic with which of the following tests best identifies patients likely to benefit from a transduodenal sphincteroplasty? A, secretin stimulation test, B, morphine neostigmine test, C is glucagon stimulation test, D is called CCK test, and E is corticotrophin stimulation test. Yeah, I figured people will have a challenge with this one. This is not something that we see as as surgeons often. This is something that mostly GI works with. Remember that we're talking about the treatment that's noted here is transduodenal sphincteroplasty, and so the disease that we're trying to diagnose is sphincter of Oddi spasm or sphincter of Oddi dysfunction. And in that situation, the correct answer is morphine-neostigmine test. Morphine causes the ampulla to contract, and neostigmine causes the gallbladder to contract, and so you're basically trying to reproduce a high-pressure biliary system to see if you can actually diagnose this pain. Secretin stimulation test is a gastronoma thing. Glucagon and corticosteroids are mostly for stimulation tests are mostly for cortisol, and CCK test is to assess for biliary dyskinesia. So when you have a situation where you have a biliary pain and you're not sure if it's because of biliary dyskinesia, you do a HIDA scan with CCK to see what is the ejection fraction of the gallbladder. But that's not what this question is asking about. E, which of the following patients should not undergo general endotracheal anesthesia for an upper endoscopy? A patient with schizophrenia who has reportedly ingested a fork. B is a patient with large paraesophageal hernia who refluxes contrast retrograde into the esophagus on barium esophagogram. C, a patient with active variceal bleeding. And D, a patient with multiple large gastric polyps scheduled for removal. So we've got, it's probably not the best worded question. I mean, the idea here is which one of these patients is safe to do sedation for an EGD? That's what we're trying to ask. And the answer here is D, patient with large gastric polyps, because these can actually be removed rather easily, and the risk of aspiration is low. Obviously, the risk of aspiration is high in B and C, and in A, you have a patient that you're not sure what exactly you're going to need to do and whether they're going to cooperate with you. So it's a matter of, you can intubate anybody, but if you're going to avoid intubation for EGD, D would be the right person to do so, or the safest one to do so. 20, in which of the following patients is upper endoscopy not needed? A, a 59-year-old white male with new onset reflux complaints. B, a 39-year-old male who is a smoker and presents with dysphagia and weight loss. C, 31-year-old male with new onset reflux. And D, 47-year-old male with a history of chest radiation from lymphoma. That's correct. C is a common phenomena and doesn't have any worrisome features. Obviously, D is a patient you're suspecting that maybe have a stricture from the radiation, and then A and B have worrisome symptoms that you are considering that they may have malignancy or underlying malignancy.
All right, and that completes our SAGES ABSITE webinar for 2016. Dr. Alseidi, thank you so much for a delightful run through that very difficult set of questions, and thanks to all the rest of our faculty as well. To the residents and others who are in the webinar, I thank you for joining us. We apologize for the technical issues, but we apparently broke the internet with this webinar and had a record participation this year, which is wonderful. wonderful. I wish you all good luck on the ABSITE itself. And the last request is please do complete the survey that we're going to post on your screen here for feedback. We really take that to heart. And thank you again, and best of luck to you all.